Medical College, Bangalore, as Senior Ophthalmic Surgeon. Dr. Mathew has completed his fellowship program from Shankara Nethralaya, Chennai. He had served as Medical Superintendent and Head Cataract Services, Narayana Nethralaya, Bangalore. And also he had served as Medical Superintendent and Head Cataract Services at Chaitanya Eye Hospital, Kochi. He is also an NABH assessor. Over to you, Dr. Mathew Kurian, sir.
Thank you. Thank you to Kaho and Drs. Nirmal and Samina for inviting me to be part of this excellent program. We'll start with what is an audit. It's a systematic, independent, and documented process for obtaining evidence and to determine the extent to which the assessment criteria are fulfilled. So what are the assessment criteria? These are a set of policies or procedures or requirements according to a standard. The assessment findings is the evaluation of the collected assessment evidence against the criteria. The scope is the extent and boundaries of an assessment. The assessor is the person or organization that is being assessed, and the assessor is a person with a demonstrated competence and authority to conduct an assessment. The types of audits are internal and external. Internal audits are also called as first-party audits and are conducted by or on behalf of the organization on its own systems. It provides objective data to plan improvements. It is done for internal purposes. Second-party audits are part of external audits and are performed by the client or its representative to ensure that requirements specified in a contract are met. For example, our hospital will need to go and visit the biomedical waste processing unit for a second-party audit. We could also go and visit the labs where we have done outsourced services. Third-party audits are performed by external and independent auditing agencies, generally against national or international standards for the purpose of accreditation or certification. Why internal audits? It's a requirement of accreditation for NABH. The management wants to discover any weakness in the hospital system before these are detected by external assessors. Internal audits can be a powerful tool for quality improvement and verify the effectiveness of corrective actions taken for previous audits. So this audit cycle starts with planning and preparation, conduct of the audit, recording and reporting the audit findings, and follow-up and confirmation of the corrective action taken. So what goes into audit planning? The scope, objectives, and audit criteria for each audit are clearly defined and agreed prior to commencing the audit. A competent auditor is one with integrity who maintains confidentiality and is ethical. There should be no biases and no conflict of interest. When to audit? According to a predetermined schedule. NABH prescribes that the internal audit should be 6 monthly and clinical audits should be quarterly. A checklist is something which provides structure and consistency and ensures that the audit is systematic and comprehensive, ensures that the audit scope is followed and all required standards are audited. But please ensure that it doesn't become a tick list. The full population data gives the true indication of standard implementation. However, this may not be always possible because of constraints of resources and time. So a sample audit can be taken as an indicator for full population, provided we control the methodology and the sample size. Otherwise, what we may see is just the tip of the iceberg. The judgmental sampling is unscientific, inconsistent, and unreliable, and statistical sampling is mandatory. Calculations are available for sample size, but a simple thumb rule is that for smaller populations, the sample size will be a greater percentage of the population, and for very large screening populations, the sample size could be just a very small percentage as given in the NABH guidebook. The audit conduct typically can be a horizontal or a vertical audit. The horizontal audit is one where a particular standard or process is audited across the organization. It is typical of individuals who are trying to implement it and looks at the effectiveness of a corrective action for a previous detected error. It is very difficult in a horizontal audit to determine the linkage between standards. A vertical audit, however, is an in-depth audit of a particular function or department against all relevant standards of the organization. Internal and external audits typically will be vertical audits, and this is where the linkage between standards gets highlighted. So if we have a hospital which has got OPD, diagnostic, ward and OT facilities, and we are looking to do an audit against the 10 chapters of the NABH. A horizontal audit would have maybe one person from the admin side going and checking whether the display of scope of services is there. Somebody from the clinical team could be looking at evidence-based uniform care. A clinical pharmacist or somebody from the pharmacotherapeutic committee is looking at sharing of consumables. HIC, infection control nurse, is looking at hand hygiene across the entire place. The CQE manager is quality manager runs around looking at quality performance, key performance indicators. The safety officer looks at fire safety. Biomedical engineer looks at calibration of equipment. HR manager looks at credentialing and privileging. MRD in charge looks at security, confidentiality, and completeness of the records. So these people are working in sort of silos. This is eliminated in a vertical audit where an individual with thorough knowledge of all the standards from 1 to 10 chapters is looking in one area, say the OPD, whether the display is correct, the evidence-based care of patients is appropriate, the MCI prescription requirements are being met, the display of patient rights and responsibilities present, hand hygiene, key performance indicators, maintenance plan, fire safety, biomedical equipment calibration, credentialing, and completeness of records. So everything is done in one area. So the knowledge required of a vertical auditor is much higher. It is easier to do this kind of a vertical audit if we follow what is called as a tracer methodology, where an individual's patient's continuum of care is tracked from admission to discharge, or in the OPD across cross-referral through specialties and lab investigations. Similarly, in a tracer method, the system can be tested by doing safety rounds, emergency preparedness, infection prevention and control, and storage and disposal of hazardous materials. The document review should be completed prior to an audit, because that is where the organization says its policies, SOPs, and manuals, what it intends to do. And during the tracer methodology, you see the evidence for that and confirm it in the medical records, HR records, etc. Specific data or information can be elicited with the interview process, and it is mandatory to have staff, patient, and senior leadership interviews. Since interviewing is such an important skill for the auditor, it is important for them to remember that open questions starting with what, why, when, who, where, and how are going to be very useful in eliciting general broad responses rather than close-ended or sarcastic questions. A non-conformance is something where there is a failure to do something that is required. It's a difference between work practice and document directly related to specific document requirement, quality system, or technical activity. It should be expressed as a non-blaming state of fact based on verifiable objective evidence. If it cannot be expressed in the words of the standard, then there is no non-conformance. If it is not written down or documented, it did not happen. Correction is the action to eliminate a detected non-conformity. Corrective action is action to prevent recurrence of a detected non-conformity or other undesirable situation. Preventive action is action to eliminate the cause of a potential non-conformity or other undesirable potential situation. So CAPA leads to NC closure, and verification of the CAPA by the auditor completes the audit cycle. Benefits are many. It contributes to organization improvement. Internal audits help employees to take ownership of processes, fosters teamwork, inculcates leadership, and provides a framework for continual improvement. Moving on to clinical audit. It is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and the implementation of change. So this is an activity to identify and fill the gap between ideal and actual practice. What is the difference from research? Research is a systematic investigation which may involve experiments based on a hypothesis. There is random allocation, new treatment, ethical approval is mandatory. It creates new knowledge about the effectiveness of treatment approaches. The findings can influence clinical practice as a whole. Whereas an audit is a systematic review of current practice. It involves measuring against pre-existing standards. There is no allocation, new treatment, or ethical approval required. Answers the question, are we following the best practice? Findings influence the activities of only the practitioners within that organization. Medical audit is more focused towards the healthcare services rendered by the doctors, while a clinical audit is multidisciplinary in that it looks at not just the care rendered, but also the structure, the process, and the outcomes as has been spoken about earlier. It can be often is multi-sectorial in that it involves the health as well as the social services, primary acute care providers, health educators, everybody is involved. A medical record audit is typically a non-medical exercise which emphasizes on the completeness of the record and not on the quality of the care given. Historically, it started very long back from King Hammurabi through Florence Nightingale, and Dr. Ernest Codman is the person who has formalized it into this modern method, which is followed as a country by United Kingdom first in 1989. The prerequisites for a clinical record are that there should be good record keeping carried out by fair and impartial professionals. Confidentiality for clinicians, nurses, staff, and patients involved should be mandatory, and the purpose is that there should be quality improvement. So when we're looking at the structure, we could be looking at the availability of resources, the quality of the building that is being there, confidentiality, privacy for patients, cleanliness, equipment safety, completeness of patient records. Structure audits are not directly related to the clinical outcomes, but indirectly offer a condition of safety to the clinical processes. Process audits would be like, for example, adherence to the timeout protocol, hand hygiene compliance, or prophylactic antibiotic adherences. Outcomes is typically what we do most frequently: the success of cataract, failure of a trabeculectomy, complications in cataract surgery like a PC rent, pain relief after an acute angle closure attack, or any change in health status or even customer satisfaction could be part of the audit cycle. So what we want to do in the steps is to identify the issue. This is based on certain criteria. Set criteria, collect the data, make the improvements, and sustain this improvement before going on to the next cycle. So how do we select the topic? It should be something which has high cost, volume, or risk involved. There must be some serious quality issue detected during an audit. There can be wide variance in the clinical practice. Good evidence must be available on which to benchmark it. There should be a possibility to change the practice, and it should be pertinent to the organization. The criteria should be well justified based on objective measures and set prior to the study. The target describes the level of care to be achieved. So we can say the criteria is that all patients with diabetic retinopathy should be seen annually, but the target should be that minimum 90% should be seen in that time period. These objective criteria are explicit, and implicit criteria are something like, was the management appropriate? You cannot have measurements on that. Sources for these kind of evidence-based standards come from NABH, the Royal UK Royal College Guidelines, NICE Guidelines, other professional bodies like the All India Ophthalmology Society. It could be research papers, or it could be just good local practice. Clinical audit topics that are followed by the UK Royal Colleges include PC rupture, visual acuity, actual versus planned post-op refraction, complication rates, and never events like wrong intraocular lenses for cataract surgery, and the list is quite a long list. Examples of policies that we have, audits that we have done in our organization. We did audit for AAC 7, where the organization defines the content of discharge summary. AAC 7A is the discharge summary in the discharge patient's note. AAC 7C could be the second criteria. Does the discharge summary have a clear diagnosis? AAC 7E is criterion C, where does it contain information on urgent care. The audit tool is yes and no for all of these, and the standard accepted is 100% yes. This is another clinical audit that we did, where we did for the diagnostic places in surgical services, cataract surgery outcomes were audited, and we looked at the diagnostic biometric accuracy, where we found that in our audit time period of 6 months, we got more than 94% of eyes within half a diopter of plano. And this was against the NHS benchmark of 85% within plano. So to summarize, we need to have a good reason for the choice of the audit topic. It should be clearly defined and it should include potential for change. In our previous example, we looked at these individuals where there was hyperopic refractive surprises and eliminated that model of IOL. How was the audit done? It should be according to strict criteria which are relevant to the subject and should be justified. Preparation and planning should show that there is adequate teamwork and methodology is carried out in carrying out the audit, and the standard should be appropriate and justifiable. Interpretation of the data should use all relevant data so that appropriate conclusions are drawn, and the proposal for change should be very detailed. Thank you very much for your attention, and thank you once again to Kaho, Nirmal and Samina for this opportunity.
Once again, thank you, Dr. Mathew, for the informative session on how to perform internal, external, and clinical audit across eye care organization. Moving further,